Hello, anatomy friends. This is Dr. Alsop, and in this video, we will be discussing the meninges. So, we will not only identify the meninges, but we'll talk about their associated features and a little bit about the differences between the cranial and the spinal dura mater. Both will have dura mater, but there'll be some differences and specializations there. So much to do, so let's get right into it. Okay, so there are three membranous layers that surround the central nervous system, and these are called meninges. The major function of the meninges is to support and protect the brain and the spinal cord, but also the neurovasculature that's going to be in the surrounding area. And so from superficial to deep, there is the dura mater, which is the most robust. It literally means tough mother. I love that name. Two will be intermediate. It'll be the intermediate arachnoid mater, meaning spidery mother, due to the spider web-like arachnoid trabeculae that we will discuss in an upcoming slide. And then the deepest meninges will be the pia mater, which means delicate mother, very intimately related to the brain and the spinal cord, so much so that you really can't pull the pia mater away from the brain or the spinal cord. They won't come up like the other layers. Okay, so the biggest difference between the cranial and the spinal dura mater is that the cranial dura mater is divided into two layers. There is the periosteal, sometimes you hear this referred to as endosteal dura, which lines the cranial cavity. So it's actually adhering to the internal surface of the bone. It's in essence the periosteum of those cranial bones. The meningeal dura is going to be closer to the neural tissue, and it's very closely opposed to the arachnoid mater. And this meningeal dura can do some really interesting things. It can separate from the periosteal layer to form dural partitions, as well as dural venous sinuses. And we'll talk more about those in these upcoming slides. So we'll start with the dural venous sinuses. So in certain locations in the cranium, there will be dural venous sinuses located between the periosteal and the meningeal dura. And these are complex networks of venous-like channels that drain relatively deoxygenated blood. That sounds familiar, right? From the brain. So very similar to veins, but these form specifically between the dura mater layers. They're going to be lined with endothelium. They have no muscular tissue associated with their walls, and there's also no valves associated with venous sinuses. Most of these venous sinuses are going to be associated with dural partitions, and there will be 13 named dural venous sinuses. We'll talk about a few of these in the lab, such as the superior sagittal sinus, which is around here on the top of the brain. We'll talk a little bit about the cavernous sinus. There'll be certain ones that are going to be more clinically relevant, and they'll come up. Now, these dural sinuses are continuous, and they're moving in the direction of draining to the internal jugular vein. So they're all kind of heading to get out of the skull. And we remember that internal jugular vein is going to begin at the jugular foramen. And hopefully we recall from labs earlier on in the year that the internal jugular vein is that large vein of the neck that with the subclavian veins, they're going to join together to form the brachiocephalic veins. We know brachiocephalic veins join to form the superior vena cava, which will, of course, drain into the right atrium. So that's how we are draining the blood from the cranial cavity region. In four areas, the meningeal layer of the cranial dura will elongate and they will form partial partitions or compartments throughout the cranial cavity and located in between very specific parts of the brain. So this is really serving to provide additional support in specific areas. There are four dural partitions, but we are going to focus on two of the most clinically relevant ones. So the first is the falx cerebri. This is the largest dural partition. It will be located in the longitudinal cerebral fissure, so it's in that sagittal plane between the two cerebral hemispheres. If you see this image here on the right, the brain has been removed, so you can really see that falx cerebri. It has this very distinctive sickle shape, and it will actually house two dural venous sinuses. You'll have the superior sagittal sinus that's along the superior border, and the inferior sagittal sinus, typically a little bit harder to see in its inferior border. The tentorium cerebelli is the second largest partition, and it's more transverse in orientation, and it will separate the cerebrum from the cerebellum. So in essence, separating the forebrain from the hindbrain. And it will have this distinctive notch. I can't see it quite as well over here, but this is referred to as the tentorial notch on its more internal or concave border. And this is where the midbrain will sit. Because we can't forget that midbrain. We talked about the forebrain and the hindbrain, but that midbrain needs somewhere to go. So it sits right here in that notch. Now, in certain pathological conditions like brain swelling or, say, a space-occupying lesion, portions of the brain, like, say, the temporal lobe of the cerebrum, that may herniate into the tentorial notch, which could compress contents in the region. So that midbrain is something that could be compressed, and the neurovascular structures associated with the midbrain, such as the oculomotor nerve and the posterior cerebral arteries. So that can compress on those structures, which would have various presentations. So the falx cerebri and the tentorium cerebelli, kind of this tent right here, and you'd have a portion of the tentorium cerebelli over here on this side. You can see a bit of it right there. Those are going to be the two dural partitions that we're going to have you identify. Okay, so let's move on to the dura mater associated with the spinal cord. Now, the dural sac is going to surround the entire spinal cord, but it's most often discussed regarding the portion of the dura that will extend past the termination the termination of the spinal cord. So this portion of the dura mater will contain the spinal cord, but remember, and you don't see it here as much in this image here on the far right, but it's also going to contain the cauda equina. You can see that over here more on this image to the left, as well as, of course, CSF. Now, remember, the spinal cord is going to end around L2, but the dural sac will continue to approximately S2. So this space right here in between the end of the spinal cord and the end of the dural sac is important in certain procedures, say, such as a lumbar puncture. So you're able to put, say, a needle in there in order to withdraw CSF to test that. And you don't have risk of hitting the spinal cord because it's already ended at L2. All right, let's take a break from the dura mater and discuss the other two meninges. So that intermediate meninges is the arachnoid mater. It is adhered to the dura mater, and it's going to be connected to the pia mater via these arachnoid trabeculae. These are these spider-like extensions of the mater that will traverse the subarachnoid space, which is going to be that space between the arachnoid mater and the pia mater. And the subarachnoid space is an important area. It's going to be filled with cerebrospinal fluid. You'll also have neurovasculature traversing the space. The pia mater is closely adhered to the brain and the spinal cord. It's so close to the brain and the spinal cord, again, you cannot peel it off. If anybody's saying I'm peeling off the pia mater, they're probably peeling off portions of the neural tissue as well. And it does enmesh the blood vessels to the surfaces, so it's going to surround those as well. All right, let's talk a bit about the spaces that do or can exist between the meninges. These can be considered either actual or potential spaces. An actual space, sometimes you just hear us refer to this as a real space, is naturally occurring, sometimes observable, It will often have contents within it, so adipose could be within there, neurovasculature, CSF. A potential space is a location that is typically opposed. So those two surfaces are typically so close together it's closed off, so it's not a real space, but can become a real space with the entrance of, say, blood or fluid or air that will separate the normally adherent structures. And there are going to be three major spaces that I want to discuss. These are going to be the most clinically relevant. The epidural space is going to be between bone and dura. And this space differs between the cranial and the spinal regions. In the skull, this is going to be a potential space, whereas in the spinal region, it's an actual space. So there's going to be vasculature and epidural fat in the epidural space associated with the spinal cord. Now, in the cranial region, this epidural space can very much become a real space in cases of, say, an epidural. Sometimes you hear this referred to as an extradural hemorrhage or hematoma. This blood is typically arterial in origin and most commonly a branch of the middle meningeal artery. And so you can have it, you'd have the bone here, you would have the periosteal portion of the dura mater, and blood can enter into that region. Obviously, that can lead to compression of the brain. There can also be epidural hemorrhages in the spinal region as too. The subdural space is located between the dura mater and the arachnoid mater, and this is a potential space in both the cranium and the spinal region. These can become an actual space where escape blood, typically venous in origin, will separate these layers that are typically adhered, particularly when we're talking about in the cranial region. And this is called a subdural. Sometimes you hear this referred to as a dural border hematoma or hemorrhage. And lastly, we've talked about this in a few other areas. There is the subarachnoid space. It is between the arachnoid and the pia mater. This is an actual space in both the cranial and the spinal regions. There will be CSF, which we have discussed a lot, as well as neurovasculature traveling through this region. But there can be hemorrhages occurring in this space. In the cranial region, this often occurs because of a ruptured saccular aneurysm. You will discuss berry aneurysms in upcoming clinical lectures. All right, excellent. Thank you so much for your time and attention, and please let me know if you have any questions.